All right, so this is the November 2025 MEC Minute, and our topic for the month is going to be a quick review of the recently released 2025 American Heart Association BCLS and ACLS guidelines. And I'm going to talk some about the guidelines and kind of cover what I consider to be key elements of changes to the guidelines that we need to be aware of. And these guidelines were just published and released last month. I know some of you have already seen them, and there's been some questions raised about a couple parts of the guidelines, particularly regarding mechanical CPR, and I'll talk about that in a little bit. We are going to focus on the updated guidelines as they're applicable to our practice. I will cover high points and maybe some low points, but there's no way I can cover everything, and this should not be considered an ACLS update for a new card. And toward the end, I will discuss how we're going to incorporate some of these guideline changes into our protocol, and also discuss those that we're not going to incorporate. These guidelines came out in late October when majority of our 2026 protocol was done. So I'm not really interested in doing a lot of rework in the protocol, and we may consider adding some additional things into the protocol in later months or years, but for now I will cover the highlights for 2026's protocol. So if you want to find the guidelines, here is the link. If you go to this link, it'll take you to a page, and you can then click and go to the individual components of the guidelines. I think there are like 10 or 11 chapters. Each chapter is on specific topics such as ethics or ACLS, BCLS, PEDS, and so on. So this is a good place to start. You can download each of the chapters as a PDF. So if you're a CPR geek, this is your key contact line. So go forward if you're interested. So if you talk about one of the first chapters, has to do with ethics and systems of care. And really, this reinforces some of the things that we have been doing over the years. So there's an emphasis on shared decision-making as approach to making patient treatment decisions, meaning the patient and or family members participate in the conversation regarding care we're going to provide. In terms of cardiac arrest, that means allowing family members to be present during resuscitation and allowing them to participate in some of the decisions such as transport, non-transport, termination, and so on. We really, as part of our cardiac resuscitation clinical standard for years, have encouraged participation of family members in some of the thought process, and we actually assign someone within our resuscitation team to be the interface with the family members. So this is really nothing new for us, but it does support our process of involving family members. I think we should recognize that allowing family members to be present during resuscitation actually has been shown to have short-term and long-term psychological benefits and outcomes for the family members, particularly in terms of how they manage grief. And the last thing about the system of care is on-scene resuscitation is preferable to patient transport with ongoing resuscitation. That is in line with our expectation that patients with non-shockable rhythms should be resuscitated in place. We have a allowance that if the patient has been shocked 5 times, remains in VF or VT, that we will transport at that time. But otherwise, majority of our resuscitations are patients in asystole or PEA, and we want to resuscitate them on scene. The likelihood of survival improves if we work them where they are. From the perspective of neonates, we know that most newborns do not require resuscitation. They need to be kept warm. They need to be stimulated. They may require a short course of oxygen to pink them up, but they do not require active resuscitation. For those children that don't require resuscitation, there is emphasis on placing the newborn skin to skin with mom and delaying clamping of the cord for at least 60 seconds. This has been shown to be of benefit to the child. So our goal is no longer to get the baby delivered, clamp the cord, and get them into a warm spot. Our goal is to get them onto mom's belly or mom's chest, let the cord stay in place for 60 or more seconds, then clamp and cut the cord. We use pulse oximetry in newborns to guide O2 therapy. We now have through AHA a chart of normative values for pulse ox. We're used to our adults with a normal pulse ox being over 90. Well, newborns don't come out with a pulse ox of 90. It's considerably lower, but they do change with time. So there is a reference chart included with the algorithm. For those children who do not respond to oxygen and have a pulse rate less than 60, we're going to start CPR. So, the key thing that we look at for children or babies when they're born is pulse rate. If it's over 100, it's great. If it's between 60 and 100, we give oxygen. If it's under 60, we give oxygen and ventilate. If they continue to be bradycardic, despite ventilation with oxygen, we'll start compressions. If patient remains bradycardic after initiation of compressions, oxygen, ventilation, we're going to give epinephrine. The other thing that they make as a guideline for infants or newborns in cardiac arrest who do not respond after 20 minutes of resuscitative efforts, we may terminate a resuscitation at that time. I know that will be very difficult to do with family present, and it may be rough on our providers, but American Heart recognizes that if the baby has been in arrest for more than 20 minutes, they are unlikely to survive, and termination resuscitation is indicated. So if we look at the algorithm, this is what we've got, and pretty much it goes with what we're used to doing. If the baby's doing well, we can put the baby skin to skin with the parent and delay clamping the cord for 60 seconds. Regardless, we want to keep the child warm. We want to dry them. We may need to position the airway a little bit. Not a lot of emphasis on suctioning the airway. If the patient has a heart rate less than 60, we're going to ventilate the child and start using pulse oximetry. If the heart rate remains less than 100, we're going to continue to ventilate the child to consider intubation. And if the heart rate drops to under 60, we're going to ventilate and start chest compressions with a compression to ventilation rate of 3-to-1, and consider starting a line. And if the heart rate remains less than 60, we're going to give epinephrine. On the bottom right there, you see the target O2 saturation rate. So I mentioned pulse oximetry in babies. So, target O2 saturation at 2 minutes is 65 to 70%. And after 10 minutes, we expect them to be in the 85 to 95%. So I found this chart to be very, very helpful in terms of how we evaluate children and their respiratory status. You might want to take a picture of this or save it somewhere. You might even post it in your truck if you do a lot of pediatric deliveries. So in terms of pediatric basic life support, they make the comment that for infants and children in cardiac arrest, ventilation in addition to chest compressions improves survival. Probably start ventilation sooner in the course than we do with our hands only. During CPR, they recommend a respiratory rate of 20 to 30. And once an airway is secured, which is more ACLS, but once an airway is secured, then we're going to ventilate them at 20 to 30 as well. American Heart did make some changes in its foreign body with airway obstruction algorithm, and this is similar to what they've now recommend for adults as well. So if you have a child with an occluded airway from a foreign body, it's 5 back slaps, then 5 Heimlich maneuvers, and you continue the cycle until you have the airway cleared. We're talking pediatric BLS. If you have the ability to use a laryngoscope and a McGill's to take the foreign body out, then you could add that to the procedure. But keep in mind, their foreign body airway obstruction algorithm is meant for basic life support, where laryngoscope and McGill's may not be available. And if you look at their algorithm for adults, it's very similar. The other recommendation they've made is with infants requiring CPR, either use the heel of your hand or 2 thumbs. The 2 fingers on the chest is no longer recommended for CPR. And finally, they suggest prompt defibrillation for VF or pulseless VTAC. This is very similar to adults. We don't shock many children, but just keep in mind early defibrillation is appropriate for children as well as adults. So if you look at the algorithms, this is kind of what we've got. On the left-hand side has to do with starting CPR. And if you look at this, our compression rate is 30 to 2, with 30 compressions, 2 breaths. And then when a secondary rescuer gets there and you have 2 people providing CPR, your compression and ventilation goes from 30 to 2 to 15 to 2. So the 30 to 2 is for single rescuer, 15 to 2 is for 2 rescuer, and then use the AED and so on, use Narcan really as part of our routine. If you look at the foreign body obstruction, again, I highlighted just the starting repeated cycles of 5 back blows followed by 5 abdominal thrusts. And you keep doing this until the foreign body is expelled. If you have the ability to do direct laryngoscopy with laryngoscope and use McGill's, you can add that to this mix. So this, again, is meant as a basic life support treatment. And assuming with advanced life support, you can use the McGill's. For adult BLS, they pretty much made the statement resuscitation be done where the patient is found. This is with the presumption that the scene is safe. If the patient's in the bed, get them on the floor. We can do better compressions. In terms of ventilation, they suggest ventilating with enough tidal volume to make the chest rise. The goal is to give enough air, enough oxygen via the BVM to move the chest, but not to hyperventilate. They do not recommend the use of CPR devices, and this would include mechanical CPR, since there's been no shown survival benefit. I'll discuss this a little bit, but we will continue to use the mechanical device, not because we're looking for survival benefit, but because we want to get an extra set of hands available and safely transport the patient. If you're going to ventilate the patient during CPR, they're recommending 10 breaths per minute, which is kind of what we've been doing. And again, the foreign body airway obstruction algorithm is similar to what we see in children. Here's the algorithm. Again, looks very similar. And then, if a patient has abnormal breathing but you feel a pulse, they need ventilatory support, they suggest 1 breath every 6 seconds or 10 breaths per minute with a pulse check every 2. This is very similar to what we already do. And really, the ventilatory rate is the same as what we do with CPR with an airway in place. So whether you're doing a BVM or mouth-to-mouth, mouth-to-mask, or with an endotracheal tube for an adult, the ventilatory rate is still 10 breaths per minute. We're going to do CPR with 30 compressions and 2 breaths. If you don't have an airway in place, once an airway is in place, whether it's an iGel or an endotracheal tube, we're going to go to 10 breaths per minute interspersed with compressions. And then, like I mentioned, the obstructed airway is similar. For pediatric advanced cardiac life support, for non-shockable rhythms, they now recommend epinephrine as soon as possible. Epinephrine, we've been using it for 60 or more years, and we're still trying to find its true place in the world of cardiac resuscitation. Really probably doesn't do a whole lot for patients in VF arrest, but for asystole and PEA, it may make a difference. But studies are starting to show that it makes a difference if you give it sooner rather than later. And this recommendation is also given for epinephrine in non-shockable rhythms for adults. Rapid defibrillation for kids is recommended for VF and pulseless VT, but we've already got that in place. And then end-tidal CO2 can be used as an indicator of CPR quality, just like we use it for adults. But American Heart is not recommending specific cutoff values for terminating CPR. So if you remember several years ago, we used to say that if the end tidal was less than 10, we could stop CPR. Now we really pretty much say that you can use end tidal CO2 as one of the things to consider when terminating, but we don't have an absolute value. So they recommend or recognize that end tidal is a good indicator of CPR quality, but they're not making any recommendations for a specific cutoff value in terms of stopping compressions and stopping resuscitation. So if you look at the algorithm for pediatric arrests, here's that recommendation that for asystole PEA, epinephrine be given as soon as possible. So really an increased focus on getting IV access early in the course of treatment and giving epinephrine early. This could be that we put an IV in sooner or an IO in sooner and really get the epinephrine in quickly. There have been some studies to suggest that intramuscular epinephrine, 5 grams IM, may be a way to reach this goal. It's not yet part of the guidelines, but I know there are some studies across the country looking at 5 milligrams of intramuscular epinephrine early in the course of resuscitation to see if there's a positive outcome. We also, if you look, there's some recommendations about no advanced airway. If you have 2 rescuers in pre-puberty patients of 15 to 2 for compressions to ventilations, 30 to 2 for post-puberty patients. So it really comes down to pubic hair, no pubic hair. No pubic hair, it's 15 to 2. Pubic hair, it's 30 to 2. And then if you have, and that's both for 2 rescuers with no advanced airway. If it's 1 rescuer, any age, it's 30 to 2 until you have an advanced airway. And then for children, if an advanced airway is in place, we're going to give a breath every 2 to 3 seconds, which is 20 to 30 breaths per minute. If you look at what we're doing with our guidelines for next year, we were making these adjustments even before these guidelines came out. So this will be reflected in next year's protocol. And then for first shock for defibrillation, it's 2 joules per kilo in the first shock, jump it up to 4 joules per kilo, and subsequent shocks can go higher than that, or use the adult dose, depending on which is the lower of the 2. So keep that in mind. And there's also a recommendation for obese children. You can go right from 4 to 10 joules per kilo up to the adult max. And then on the right-hand side, I have the pediatric tachyarrhythmia with pulse algorithm, and it talks about the synchronized cardioversion values and using adenosine for SVT. We tend to go with 12 milligrams, but they're at 0.1 per kilo to a max of 6. If you have a large child, I would probably consider giving the adult dose. I did not put in this talk the algorithms for bradycardia and wide complex tachycardia because they really are not much different from what we already have. So I put this one in place, and it really is a pretty good breakdown of how we should take care of children. Next up is adult cardiac life support. And, if you look at their recommendations, they indicate that, for AFib and A-flutter, if we're going to counter shock or cardiovert these patients, really need to start with a higher energy. So you need to start with at least 200 joules for conversion of AFib or A-flutter. The guidelines also include updated termination resuscitation guidelines, which basically say if you've had good resuscitative efforts and you've had no resumption of circulation, no ROSC, particularly in asystolic and PEA arrests, you can stop after 20 minutes. We are going to make this change in our protocol, drop from 30 to 20 minutes, and you can terminate. They also point out, at least from the perspective of American Heart, that the usefulness of vector change or dual sequential defibrillation for refractory VF is not well established, so it is not currently recommended. We will continue with vector change in refractory VF. I'll talk about that at the end. They discourage use of heads-up CPR unless it's part of a research project. We gave heads-up a try a year and a half ago, and we did not see any change in our outcomes, so we stopped it on our own. and we have no plans to restart Heads Up at this point. The American Heart no longer recommends endotracheal tube medications such as epinephrine. Their preference is IVIO. Although endotracheal tube epinephrine for intubated newborns is still accepted as a reasonable clinical practice since IV access in newborns is difficult. They also start talking about use of point-of-care ultrasound as a way of evaluating for ROSC or evaluating for perfusible rhythms. So if you have a patient with PEA or REST, ultrasound may help guide you in terms of, is the patient truly PEA where there is no cardiac activity, or do they have cardiac activity but no palpable pulse? And we can use point-of-care ultrasounds, but we cannot use it in a way that interferes with CPR. So we are starting to look at point-of-care ultrasounds, may do a trial next year, but I can tell you that trying to get good images of the heart with a point-of-care device during CPR is extremely difficult, and the learning curve is substantial. So I'm not sure what role point-of-care ultrasound for EMS in the field is going to be in terms of cardiac arrest. The guidelines also point out that torsades should be considered unstable and should be defibrillated. We are making adjustments in our protocol so that if the patient has torsades, we're not going to try mag sulfate first. We're going to shock the patient and then give mag sulfate. Torsades is considered unstable. It's an unstable tachyarrhythmia, should be defibrillated immediately. And then finally, one of the recommendations they make is that IV access is really the first line choice for medications. IO should be used only if you're unable to obtain an IV. I think that's a bit of a balancing act. If you have a patient who has nothing for veins, IO it may be the better choice. But if you have patients with reasonable veins, we should try for the IV access first. There have been studies out there that show IV delivers better. There's better delivering medications than IO, but I think we should point out that those studies look at IV versus tibial IO. I'm not aware of any studies that compare IV access versus humeral access. The imaging I see is that humeral access really has rapid delivery into the central circulation. So I'm comfortable with using humeral IOs, particularly if the patient has no readily available veins for IV placement. So here's the ACLS algorithm, and it looks pretty standard. Again, patient's got a shockable rhythm. We shock first and quickly. If the patient has asystole PEA, we need to move toward getting epinephrine as soon as possible. We need to work that into our algorithm. For next year, we will have a statement that we should give epinephrine as soon as possible. May need to change some of your priorities in the field when you are resuscitating patients. We've kind of put IV access as third or fourth priority on our list. We may need to move it up and do it quicker. For me, there's that conflict between trying to get an IV started versus the rapidity of doing a humeral IO. But we will make an emphasis on early epinephrine. We just have to work on our processes in the field. And then I also threw up the algorithm for bradycardia with a pulse, and atropine is, if it's ineffective, go to transcutaneous pacing or dopamine and epinephrine. So I think for me, this kind of places an emphasis on trying atropine once, quickly making a decision. If it doesn't work, to go to transcutaneous pacing and consideration of epinephrine infusion. We do not have dopamine on our trucks anymore, but we have epinephrine. We have a push dose epinephrine available, and we have a protocol for starting an epinephrine infusion. So bradycardia, if the patient is not doing well. It's quick use of atropine followed up with pacing, and then early implementation of epinephrine infusion if the patient doesn't respond. So, keep that in mind. And if you look at the box on the right, it calls for epinephrine at 2 to 10 mics per minute infusion. And we do have a chart in our protocol that identifies the infusion rate, how many milliliters per minute in order to reach this infusion rate based on micrograms. So special circumstances on post-arrest care. I think some good comments there. Cardiac arrest due to anaphylaxis. Patients would benefit from IV fluid boluses. And there is a mention that the auto-injectors are unlikely to help patients with an anaphylactic reaction if they're in cardiac arrest. So if you have anaphylaxis, cardiac arrest, if you're a BLS provider, use the auto injector. But if you're ALS, as soon as you can, get IV epinephrine started, whether it's a bolus because they're at arrest or an infusion because they're hypotensive. So I think that's an important point to be made. We have added some additional guidelines to IV epinephrine use in allergic reaction as part of our 2026 guidelines. There's also a mention about IV glucagon for beta blocker overdose. We carry glucagon, so that is an option for you. There is also a mention about ECMO for refractory VF. ECMO is extracorporeal membrane oxygenation, basically putting the patient on bypass. This has been shown to be of benefit in facilities, hospitals that are high performers. There are not a lot of high-performing ECMO centers across the country for out of hospital cardiac arrest. Really, we tried it in Columbus, didn't go that well, but we may see more in the future. There's also a comment that the utility of intravenous calcium and or sodium bicarbonate for hyperkalemia, it's uncertain whether or not it really is effective. We will continue to use it. IV calcium is the antidote to hyperkalemia, and sodium bicarb helps with adjusting or driving potassium back into the cells, which is where most potassium resides. There may be uncertainty, but if the patient's in arrest, we're going to use it. They also provide an algorithm for LVAD, and I'll show you that in a minute, with the key decision points being mean arterial pressure and end tidal CO2. I think it's one of the better algorithms I've seen. We need to really talk about how you can get a mean arterial pressure in someone who is on an LVAD because they don't have a pulse. So Doppler devices help identify the mean arterial pressure, but it's part of the assessment. End tidal CO2, particularly in patients who are unconscious or have an artificial airway, is a key marker for a patient being in arrest or not being in arrest. There also is a comment that it may be reasonable to give naloxone to cardiac arrest secondary to suspected overdose. So we're not talking about patients who are apneic but have a pulse. We're talking about patients who are in cardiac arrest. This is similar to the recommendation they gave 5 years ago. I would think that by now we'd have a better idea of whether or not naloxone actually helps for a patient in cardiac arrest. And then there's a guideline that after we have ROSC, our goal should be to maintain a mean arterial pressure of at least 65 millimeters of mercury. For us, that means if the patient is hypotensive, probably using epinephrine drip to bring their pressure up. I think everybody should be aware that more and more emphasis is being placed on using epinephrine drip to maintain blood pressure for pre-hospital patients. So if you're not comfortable using epinephrine infusions, please talk with your coordinator. We'll work out some training on it. It does work. So if you look at the post-arrest care, this is the algorithm. At the top box talks about maintaining O2 saturations of 90 to 98%, and our target CO2 is 35 to 45. We don't want to underventilate, but we also don't want to hyperventilate patients who have an artificial airway. And talks about our target mean arterial pressure of 65 or more. And if you look at the box here, it pretty much summarizes a lot of what I've been talking about. Manage the airway, manage oxygenation and ventilation. So we have a good pulse ox of 90 to 98%, and we have a target PCO2, end-tidal CO2 of 35 to 45. We want to manage the patient's blood pressure using vasopressin or fluid as needed for a mean arterial pressure of 65. The other thing is if you have a patient with ROSC, they need a 12 lead. So part of our process has been and will continue to be, if you have ROSC, get a 12 lead electrocardiogram as soon as possible. And then this is just the same thing. I magnified it for you, and it's pretty straightforward. Finally, LVADs. These devices are out there. When the LVADs first came out, they were meant as bridging devices, meaning they were meant to keep the patient alive until they could find a donor for a heart transplant. Probably the majority of the patients on LVADs now are patients who have destination devices, meaning they have an LVAD and they're going to continue with the LVAD and they're not being considered for transplant. The only device out there right now is the HeartMate 3, and the experts on these devices are the patient and their family members. So if you get called on a patient and it relates to the LVAD, talk with the family members because they've been trained how to problem solve. The other resources, all the LVADs are tied to a facility, whether it's OSU, Riverside, Cleveland Clinic, University of Cincinnati, and there's always someone on call for that facility. So if you have a question about the device, you can call them and they'll help problem solve on the phone. If you look at the algorithm, the key questions are whether or not the patient is perfusing. And if the patient has evidence of perfusion, then we're not going to do CPR. We're going to evaluate the LVAD and look for other causes of unresponsiveness. So if the patient's a little hypotensive, but the patient seems to be having a working device, maybe they need a little bit of fluids. If the patient is having some other devices like an alarm fault, work with the family, work with the LVAD coordinator to figure it out. If the patient has evidence of inadequate perfusion, then we're still going to evaluate for function, but then we're going to start CPR. We will not use mechanical device for CPR in these patients. So how do we assess for adequate perfusion? Well, it's up here. So adequate perfusion, if the patient has normal skin color and temperature, if they have normal capillary refill, then they are perfusing. If their mean arterial pressure is over 50, then they're perfusing. So maybe the heart's not working well, but the pump is moving the blood around. The problem is you're not going to get a great pulse. So you need to find a way to determine the mean arterial pressure. And the best way to do that is with a Doppler where you listen for pulses. I keep in mind that the MPATS board recently changed scope of practice. So using a Doppler device to find pulses is in scope of practice for EMTs, advanced, and paramedics. So if you have a Doppler available, you can find a pulse. You can use a blood pressure cuff. You will lose the pulse, but as you deflate the cuff, once you start hearing the whoosh, whoosh, whoosh coming from the Doppler, that's your mean arterial pressure. If that's over 50, the patient's perfusing adequately. And the last thing, the way to evaluate for adequate perfusion is if you have to intubate the patient or the patient has a tracheostomy, you can get an end-tidal CO2 off the supraglottic device, off the endotracheal tube. And if that end-tidal CO2 is over 20, then they're considered to be having adequate perfusion and the device is working. They have something else going on, whether it's a stroke or a hemorrhage, that's causing their altered level of consciousness. So how does all this relate to our 2026 treatment guidelines? So I'm kind of covering those things that we're going to adjust. Some things we're just not going to do. And like I mentioned earlier, there are some things we may make as changes in the future, but not as part of the 2026 rollout. So for newborns, we have added that we're going to delay cord clamping. So if you have a healthy newborn, They're picking up nicely. You don't have to provide ventilations with the BVM. You don't have to do CPR. We're going to take the baby, put it on mom's chest, keep the baby warm. The babies are little radiators and lose heat quickly. We're going to keep them warm. We're going to delay cord clamping for 60 seconds or more. We'll then clamp the cord and cut it, and we'll proceed with placental delivery as per our protocol. For the neonatal resuscitation, the AHA guidelines have a nice algorithm, but Dr. Kadish and I earlier this year decided we're going to go to the NRP algorithm for pediatric resuscitation. We're going to keep it since we've already inserted it in the protocol. It is very similar, if not identical, to the American Heart Association guideline. It just looks different. So we're going to keep what we've changed, really no substantial change in how we're going to care for the babies. In 2026, we have adjusted the the respiratory rates for CPR for infants and pediatric patients. So we'll be in line with the standards. It was an oversight that's been there for a couple of years. It's been fixed. In terms of IVs versus IOs, if you have the ability to get an IV, try once, try twice. American Heart says 3 tries, which to me is too many. But give it a try. If unsuccessful, go to the IO, go to the humeral IO, which is preferred over the tibial. We have to balance between how many times we're going to try versus we need access so we can give epinephrine for this non-perfusing PEA asystolic arrest. In terms of mechanical CPR, we will keep it. American Heart says or does not recommend any mechanical devices or CPR assisted devices because they're not associated with better outcomes. Well, I think the important thing for us to keep in mind is mechanical CPR devices, particularly Lucas, has been shown to be non-inferior to manual CPR, meaning it's not worse than. So it'd be nice if it was better than, but it's not worse than. So we're not looking for using mechanical devices for better outcomes. We're looking to mechanical CPR to free up our hands. The device is set to give compressions at a depth and rate in line with American Heart recommendations. It will keep our providers safely secured in the chairs during transport if we have to transport. And if we are providing care in an environment where we don't have a lot of providers available, mechanical CPR will do CPR until the battery runs out, and we have that extra set of hands to help with patient care. In terms of epinephrine, we're going to we added a comment to our ACLS guidelines to give it as soon as possible for non-shockable rhythms. And again, that goes back to IV versus IO and how quickly we can get one done. And we're also adding emphasis on push dose and infusion of epinephrine for hypotensive patients. If you are not comfortable with diluting medications or diluting epinephrine for push dose or mixing up and infusing an epinephrine drip, please talk to your EMS coordinator so you can have the training you need. In terms of termination of resuscitation or TLR, we're going to reduce the time requirement to 20 minutes. I know there was some consternation among our crew members when we went from 20 to 30, but now that American Heart says 20 minutes is adequate, we're going to go back to 20 minutes. Also keep in mind that if you have a patient in cardiac arrest and a healthcare provider is doing CPR before you arrive, their CPR time counts toward that 20 minutes. So, I think this, for our providers will be welcomed. In terms of torsades, we're going to add a comment to shock first and then give mag sulfate. So we're still going to use mag sulfate for torsades, but electricity comes before medication. So that you'll see that change. American Heart also does not endorse vector change or dual sequential. We are going to stick with vector change. So it's going to stay 3 shocks for via standard placement, anterior and lateral pad placement. No change. We're going to go to anterior posterior. I think there is enough justification to go to vector change. We use anterior lateral pad placement as our go-to for the first shocks. And then anterior posterior. If you watch what the cardiologists do when they cardiovert somebody or they're involved with care, they just go to anterior posterior. They don't do the standard anterior and lateral. That tells me that there's value to both methods, And if one method doesn't work, let's go to the other. I think it's reasonable to do. For hyperkalemia, we're still going to continue with calcium and sodium bicarbonate for patients who are in arrest and have a history of dialysis. Um, the American Heart may not be totally enamored with the data and what it supports, but I can tell you it's standard of practice that if you think the patient's hyperkalemic, we use calcium and we use sodium bicarb. And then the last thing is the LVAD cardiac arrest protocol is going to be revised. I haven't decided yet whether we're going to use American Heart's version of the algorithm or the algorithm that comes from the LVAD Society, International Society. They're both good protocols. I think the American Heart one is probably easier to understand and more straightforward. I'll work with Cody on getting that into the protocol. So the 2026 protocol is mostly done, but the LVAD change will be a late entry, but it will be there before it comes out on January 1st. So finally, that's it for my review. If you have any questions or concerns, please send your comments. If you have any questions about something I didn't specifically cover, I'd be glad to hear from you. Thank you.